Everybody, I'm Brian Buchanan, one of the ICU doctors. This is a case-based discussion about lung ultrasound and critical care. I picked a few cases that I thought would be interesting, kind of provide some insight into the kind of general approach of using lung ultrasound, thoracic ultrasound. I hope this to be interactive. I find Zoom is a bit punishing that way, but please do not hesitate to speak out and provide some potential solutions or answers where you see fit. But I hope that some of you can take from this that you can use lung ultrasound to really detect key pathologies in acute illness, and that there are both artifactual and non-artifactual findings that really do impact the differential, and talk about some limitations, false positives and false negatives. Case one. This is I should mention that Dr. Milovanovic or Laz will also be on the line too from the nuns, and he's going to present a case as well. So I'll go through mine first, and then we'll have Laz present his. So this actually is also a case that Laz saw. This is a 56-year-old female, history of squamous cell carcinoma and a total laryngopharyngectomy, has a stoma. She was admitted with fever, chills, and she was transferred from up north, expected to be community-acquired pneumonia with fairly substantial Xray findings, which I'll show you shortly. She was requiring 11 liters of oxygen. She's receiving pip-tazo. You'll notice it says pip-taco. I just thought that was funny, so I just left that there. And subtriaxone. And eventually a trach tube was inserted, and she was put on the ventilator through her stoma. So this was her X-ray here. You can see that there's a large degree of right-sided infiltrate. It's almost across the entire thorax. There's been a line inserted here on the right and a host of other lines as well. And these are often difficult X-rays to interpret because, of course, an X-ray is a two-dimensional image of a three-dimensional structure. So there's lots of overlying images. The radiologist felt that the changes were non-specific, could be pneumonia or aspiration pneumonia, and maybe an associated parapneumonic effusion. So at this point, it was kind of unclear whether this was truly an effusion or consolidation or a bit of both, and kind of what to do next. Now, a lung ultrasound was done, just to kind of further clarify. This is R1. This point is at the mid-clavicular line, second or third intercostal space on the right side of the chest here. That's R1. And can anyone tell me what they see here? Any ideas? So we have a linear probe, right? Fairly square waveform. Okay, we have some soft tissue, some muscle up here. And this right here is the pleural line. Okay, albeit this depth is not great. Usually about 10 centimeters is the minimum depth for the anterior chest wall. Okay, and there is some, looks like, we're looking at the pleural line. This is where the visceral and parietal pleura have immediate apposition. And we don't see kind of full sliding here, but we do see some suggestion that there is pleural apposition, albeit it's quite a weak slide. But nonetheless, I doubt there's a pneumothorax here, recognizing that this view is maybe not optimal. Okay, so usually 10 centimeters. The linear probe does help clarify pleural findings, but it's not the best for depth. Okay. Moving on to the right side of the thorax. So you can see here, this is acquired roughly kind of anterior to mid-axillary line, about 5th or 6th intercostal space. You can see there's some suggestion that's obviously quite dark here, or black. Black in ultrasound generally means fluid, okay, unless there's a bunch of ribs here, but that usually means that there's a scattered rib interface. But here it's just uniformly black. And you can see that's quite likely the liver, which is recognizable by its kind of fairly homogeneous and gray texture. And then there's kind of a hypercoic kind of rim along that liver, which looks like it would probably be the diaphragm. Okay. And then here, quite likely the lung, but not ideally seen. And then this would be the spine. So generally we don't see the spine above the diaphragm in an inflated lung, because the inflated lung will block penetration of sound waves, and you'll just more or less see the kind of white shimmering pleura. So normally you don't see the spine. So this has resulted in some people calling this the spine sign, which means that must be a consolidation or a fusion here, which gives an acoustic window. So, this almost certainly looks like a pleural effusion. I'd be very careful though to make sure that in fact I am seeing the diaphragm here, because you can certainly have subdiaphragmatic effusions, which can look quite similar, especially if the image quality is not crystal clear. Another image essentially the same, but again, spine. We definitely know for sure that this is fluid. Okay, this is a little more clear here. You can see the diaphragm quite clearly. Okay, and fairly large. This is kind of the pleural space margins here. Chest wall, that's lung, diaphragm, and spine itself, okay? Looking at the left side of the chest wall, was fairly banal. There's a hypercoic line there. There's the rib margins, this is kind of the bat wing appearance. So you have dropout below the ribs because the sides can't penetrate below the ribs. And you have this quite obvious sliding here, this hypercoic line, which is just normal lung. Now, we don't see the artifacts terribly well below the lung. Normally, we'll see either kind of things like A lines or B lines. A lines are a reverb artifact, which are horizontal, and the same depth as, say, from the probe to the pleural line will repeat. So probably around here would be an A line. There's no obvious B lines here, but I have a suspicion that this wasn't acquired directly perpendicular to the pleura. Nonetheless, nothing gross here, nothing like the right side. So given the story, fever, chills, there was a pigtail insert in the right chest to drain this off. Patient obviously did present with this pneumonia-like syndrome and parapneumonic and queer parapneumonic effusion. And based on the ultrasound images, it looked like this was indeed a pleural effusion. So with putting the chest tube in, they drained off about 1.5 liters of frankly purulent material, had an elevated white cell count and a pH stat, I think it was around 7.12. The culture did grow group A strep, and the CT post drainage showed a small amount of residual fluid and early necrotizing features of right upper lobe. This lady did go on to have quite significant thoracic pathology and had a frankly necrotizing pneumonia and this empyema. So thankfully, she was managed with a long course of antibiotics and TPA DNase, but no need for decortication. So I don't think this was necessarily a fancy case. It's just a sick lady with an impressive chest X-ray findings and obviously a high pretest probability of infective process. The ultrasound was not overly suggestive of an empyema. Of course, it did show a black or anechoic space, but there's no loculations. There was no significant kind of hypoechoic or echogenic material within the pleural space, and ultimately required a diagnostic thoracentesis and some therapeutic drainage. But I think I just wanted to highlight that there's a couple of things here is that ultrasounds don't always show you that a pleural effusion would be exudative, okay? And they can be pretty black and simple appearing on ultrasound and CT, okay? But still be infected. And I think that's often a misconception that if it appears normal on ultrasound or a CT, then it's not infected, but that's actually not correct. Of course, the actual pretest probability is probably far more important than what you'll find on any kind of imaging. And this just highlights that often there's this discrepancy between what we see on ultrasound and what we see on an X-ray. And this is a fairly common finding in the ICU, and I expect it's fairly common amongst most medical wards or most people who admit patients with these kinds of infections. Any questions here on this case? It's just the ultrasound rounds. You're welcome to come. Yeah.
No worries.
Yeah. Oh, sure, no problem. Okay, so case 2, 64-year-old male, person who injects drugs with 5 days of shortness of breath, fever, chills, unvaccinated with a sore right elbow. He's sweaty, diaphoretic, he's pale, he's uncomfortable. His respiratory is 32 and he's on 65% optiflow. And, he doesn't look that, he actually looks quite pale and quite sick. His white count is 28, roughly to 31 on a repeat draw. And the COVID's pending. At this point, it's thought that this is probably COVID because unvaccinated, hypoxic respiratory failure. He's not your typical, happy hypoxic, which I think is a stupid term, but does describe a state where someone can be hypoxic but not overly short of breath. So at this point, the thought is, it's probably COVID. Let's just admit him to the ward and let's just get this over with. Here's his X-ray. Okay, and I don't know if anyone wants to make a comment on the X-ray, if there's any particular remarkable findings.
Some right lower zone infiltrates and minimal bilateral pleural effusion.
Sorry, you kind of broke up there a little bit there, Nazia. Can you repeat that, please?
I was just saying that some right-sided lower zone infiltrates and bilateral minimal pleural effusion.
Yeah, I think that's right. I mean, it's hard. I mean, the more that I do ultrasound, the more that I'm skeptical of my own reading of chest X-ray. But I think you're right. I suspect there is some blunting here of the costophrenic recesses, and some, the right lower side does look like there's more infiltrate, and maybe some scattered infiltrates throughout. Now, it was read as bilateral mid and lower lung zone infiltrate, suspicious for multifocal pneumonia, including COVID. And there was some suggestion that maybe it's possible upper lobe collapse and lateral view without anything on the frontal projection, could be mucus plugging, and then they require a repeat X-ray. Now, at this point, when I saw this gentleman, I thought, yeah, the X-ray is not overly suggestive. It could be compatible with COVID. COVID X-rays are fairly boring with scattered infiltrates. But based on the white count of nearly 30 and the fever and the kind of diaphoresis and pallor that this gentleman looked like, I thought, I'm not sure if we really have a diagnosis. And this time the COVID test was pending. So we went and applied some lung ultrasound in the emerge. He also has tender elbow, which I should emphasize too, which was red and hot. And so the X-ray of the elbow was negative. There was no obvious effusion. We had called ortho to tap it, but at this point in time, we had no details. Anyways, in the meantime, the emergency physician had started dexamethasone steroids and started empiric antibiotics for community-acquired pneumonia with some suspicion of maybe a superimposed infective process, albeit the X-ray wasn't overly helpful, most on the basis of the white count. So given that there was this sore joint and the story, we kind of felt like maybe we needed a better workup. So we did the lung ultrasound in the emerge, and this was our first image. This is at point R1. This is the same point we started with here, is that it's kind of mid-axillary, second intercostal space, where we normally would expect like pleural apposition, like lung sliding, very typical lung findings. Okay, but maybe that's not what is shown here. Any idea of what this could be here? Or what's this here at the very least, this black part? Any ideas? If you were to emerge, yeah, go ahead, sorry.
Is it fluid?
Yeah, it's fluid, yeah. Yeah, that's right. It's fluid. It's fluid. And it's bizarre. This is not the kind of appearance that I suspected, not based off the X-ray. And then there's this structure down here, which is mixed density. There's, it's a very linear hypercoic structure with some more hypocoic around it. And, I thought this was most likely going to be lung with the intervening pleural effusion, which again, I was not exactly expecting. So I moved along here and kind of took a look at the anterior chest wall and thought, well, if it's in one location, where else is it? So I explored a little bit further. There's more of this hypocoic lung texture. And then there's also these, what looks like almost like pockets, okay? And I'm not exactly sure at this point what I'm looking at here, but I was convinced that this is lung and fluid. Looked a bit more, again, I can see more of those, what looks like now, almost like a fibrin strand. So I'm wondering at this point, is this locules? And there's that big black space here with the chest wall right here. And then again, more of what looks like lung. But I recognize that this is a very complex image to interpret. But I think hopefully all of you would agree, this looks vastly different from a normal lung ultrasound. So this is a little more down. It's about fourth intercostal space in the right anterior chest wall. Again, there's that lung. There's some more of that fibrin stranding, more fluid. Right peristernal, there's more fluid as well, more of that lung. So I moved down. There's the second space. This is anterior axillary line, about fourth intercostal space on the right side. And that's a little more consistent. Looks like there's some sliding there with some B lines. So maybe the lung there is de-aerated or has some infective process, but clearly the lung's not functioning normally here. And then I get down to the fourth space. And does anybody here want to hazard us maybe a kind of a query as to what we think is going on here or what they see?
Empyema, Brian, is this a loculated empyema with consolidated lung? Were there B lines in that very first image you showed as well, where that anterior pleural effusion was? Was there lung with B lines underneath that?
It's hard to say if they're truly B lines. Certainly, like the lung is compressed, and what you have there, that hyperchoic line, is probably in fact an air bronchogram. It's probably just air that's trapped in the lung itself. And can't escape, and generating this very strong signal, which can look like a B line.
Okay.
But yeah, here we see these fibrin strands, right? That they're kind of intermittently available, intermittently seen. There's a diaphragm, there's the liver, and this is the pleural space. So head would be here, legs would be here. This is the chronal plane at posterior axillary line. Yeah, and it looks like there's maybe some kind of fibrin strands there, which suggests maybe this is an empyema, and that would make sense given the anterior chest wall findings of these pockets of fluid with this lung that looks like it's not exactly adherent. We had a transverse view, okay, and the transverse view is a little more complicated to understand. It involves flipping the probe 90 degrees. So we can see here, this is the transverse view. So Dr. Meyer, this again would support what you're saying, that there's multiple loculations here, okay, multiple fibrin strands. This is for sure kind of a complex septated effusion. You also have to be leery that you know kind of what you're looking at here, because you can easily be below the diaphragm, albeit this looks like this is probably liver centrally here, outer diaphragm, and then chest wall. I moved up and down the chest wall to make sure I in fact was above the diaphragm, and this finding was fairly consistent. This is a fairly generously sized complex septated pleural effusion. Now, to understand this view, this is kind of an example here. You can see the diaphragm, the pleural space, and then the liver. So this is like a hemothorax transverse cut. There's obviously lots of septations there you can see. Any questions on this particular image? So this is the outer chest wall, as you can see here, and then the pleural space. So again, complex septated. After this is a right sagittal view on the anterior axillary line. You can see again those thick septations. The left side, you can see here that there's some lung sliding. Okay, there's maybe some B lines here on this right side of the field, and maybe some subpleural consolidation below the pleura. And then L2, somewhat similar, some more B lines, maybe some drop in aeration as part of the lung. Essentially, left side just showed some likely consolidation of the left lower lobe. But basically, at this point, based on what we found with the high white count, the fever, the way this gentleman looked, and the sore elbow, we thought, like, what's really going on with this guy? This doesn't really seem like this is COVID. And based on his very poor looking appearance, we decided to actually intubate this guy in the emerge and send him for a CT. So into the donut of truth we go. So here's one of the first cuts we see. Can anybody point out any unusual looking features of this CT?
There are definitely pockets of fluid that shouldn't be there in the paraspinal region as well as anteriorly. Yeah.
Yeah, I agree. This is certainly like there are pockets of fluid here, and they seem to be a bit patchy throughout the thorax. In fact, you can see here more as you go a little bit lower in the cut. They're kind of more involved, either the mediastinum and a little more paraspinal, as you pointed out, Charles. So this guy actually had quite a few pockets of fluid, including posterior thorax. There was an air bubble here. There wasn't much made of this. So basically the thought was this is simple fluid density. There's no peripheral enhancement, it's just empyema. Now, I'm not surprised by the CT because this is often the thing we see on ultrasound that may not be picked up on CT. I don't think there's actually any locules they could see on CT imaging. And I've seen this probably half a dozen times now where the ultrasound shows quite obvious loculations, and those do not appear on CT. So no pleural enhancement. So the thought was this is unlikely to be empyema, which again I thought was a bit strange given the findings plus the pretest in this gentleman. Nonetheless, the guy grew Staph aureus from his cultures in both bottles within 8 hours. So within 8 hours past admission, this guy had Staph aureus in his culture. So eventually, a pigtail was inserted. He drained purulent material, and it's pretty nasty. Low pH, frankly infected. So TPA and DNase was used. But I'm not surprised. This didn't really fix the problem. Based on what we saw in ultrasound and CT, these are multiple pockets in different spaces, and they're not necessarily contiguous. So the actual paraspinal and parasternal collections did fluctuate, but ultimately were not really, I don't think, actually even reached by the TPA and DNase. So he eventually did require decortication to get rid of this nasty empyema. So reviewing this case, I think this is important to highlight that when we have these cases that come in with, query COVID, it becomes very hard to stop the COVID train. But obviously, we have to evaluate each circumstance as if they were here in the time before COVID occurred. And, obviously a high white count, frank diaphoresis, and just this clinical presentation was more consistent with a different disease process. And the chest X-ray was largely incorrect, maybe even misleading. And I think that's the other problem we deal with when we look at just using X-rays alone to evaluate patients. In fact, some places I understand in Germany, there's a couple of hospitals which do almost empiric CTs on every COVID patient. Now, I think that's nuts, but I think that is one strategy to overcome some of the problems with using X-rays to evaluate this very heterogeneous group of patients. And the ultrasound findings were much more predictive of a complex loculated effusion. And the CT, in fact, kind of seemed to reduce the post-test probability. But I think perhaps that was actually an incorrect measure because, yes, there's no pleural enhancement, but obviously given the presentation, the white count, the loculations, that this should have been evaluated more with kind of a higher degree of suspicion. The joint did eventually grow Staph aureus. Of course, all this happens in retrospect, so it's easy for me to say this. So I suppose that's one big caveat to any case. But any questions on this case too? Any comments or feedback? Anything I didn't talk about?
Great case, super interesting.
Thanks. Okay, so how we evaluate the chest is variable. You can really use any probe. The issue is if you use a linear probe, you don't have much penetration. So normally you'll get 6-10 centimeters. Now we usually look at artifacts in the lung, like A lines, B lines, pleural sliding. But when the actual lung, when there is frank pathology like consolidation or pleural effusions, it's actually no longer an artifact at all. It's just lung and fluid. So an artifact would presume that it's not in fact there. So A lines and B lines are useful artifacts, but they are artifacts. But pleural effusions and consolidated lung are in fact just things you're actually seeing. So you can use a curved probe, curvilinear, which has frankly pretty low frequency, 2 to 5 megahertz, or a phased array. The phased array has a very low footprint and fans out, whereas the curvilinear has a broad footprint. Both can be used to assess the chest, and I think it would be important for most people to become facile with both. Particularly in patients with lots of adiposity, the curvilinear probe can be an asset just because of its very low frequency. The standard 8-point exam, R1, R2, R3, R4. This R2 here is anteraxillary line, about 3rd or 4th interspace, and then mid-axillary line is just at the level of the diaphragm. And then posterior axillary line, this is more posterior, but it's on the posterior axillary line, again, at the level of the diaphragm. And this is not this right here is not assured. You don't technically know where the diaphragm is. I think that's really important to highlight, because making the assumption you know where the diaphragm is what leads to abdominal chest tubes. And I've seen that before, because you just can't always guarantee where the diaphragm is or should be. So here's, again, a typical chronal plane with the probe marker that's pointed cephalad. So the machine itself should be on, say, abdominal setting, usually not a cardiac setting. The depth usually around 18 to 20 centimeters, but usually I just suggest that people put the spinal, the actual spine in the far field. That way it maximizes your visualization of the pleural space. So the opaque hemithorax is fairly challenging for a lot of reasons. You know, pneumonia, certainly we see that all the time. Mucus plugging, dense consolidations, massive pleural effusions. Pneumonectomies, of course, usually this will fill with fluid post-pneumonectomy. Cardiomegaly, that's another challenging one, can fill an entire hemithorax, believe it or not, in severe cases. Obstruction of the main bronchus, endobronchial tumors, of course, foreign bodies. That's your typical differential. I think what I missed on here as well was just that, we make this assumption that it's all consolidation or it's all fluid or it's a mix of both, but it can also be the diaphragm. With a raised hemidiaphragm can really give you an appearance of a right opaque hemithorax, I should say opaque hemithorax. And of course, we use these typical findings like where the trachea deviates, like if it's pulled towards, then it's lung collapse, right? Because you decrease the actual volume of the thorax. So pulmonary genesis, pulmonary hypoplasia, and then in central positions like consolidation, pulmonary edema, and then other kinds of ones that will effectively not change the kind of relative volumes in the thorax. And then pushed away big pleural effusions, diaphragmatic hernias, large masses, which eventually increase the size of the hemithorax, pushing away the trachea. So of course, but these are fairly crude. I don't think these are used to look at an X-ray, but I think clinically I'm very cautious. I do look at this, but I am very cautious to make sure that I don't jump to a conclusion, because what I would like to do, ideally in most patients, is kind of debias myself, is to think, the X-ray suggests this, but let's just make sure it's not something else, or let's make sure we rule out an effusion or a consolidation or a raised diaphragm or blood or what have you. So here's an example of two frank differences: large volume pleural effusion and a consolidation. Okay, the consolidation is fairly homogeneous. There is some hyperchoic areas, which are probably bronchioles, seen on end, which are filled with air. And then again, there's that pleural space, fairly anechoic. There's lung there, diaphragm, and then liver. And then there's the spine, which again, that spine sign, which we see when there's an acoustic window. Another example is subdiagrammatic ascites. So we've got to be careful with looking at the diaphragm, because of course you can have fluid above and below the diaphragm. So you got to be, I triple check to make sure I know exactly where I am. And if I can't see the diaphragm, I can't make it out reliably, then I would invariably progress to CT if I think that the patient depends on definitive diagnosis. So in many cases, we do a chronal plane ultrasound. This is an example from the left mid-axillary line. So probe would be the marker pointed cephalad. Okay, so head here, feet here on the image, and again in the chronal plane. So with the diaphragm and subdiaphragmatic viscera to be on the bottom left. So this would be spleen in this case. Okay, and this is a very common way. If they're sitting upright, this is a great way to evaluate the size of an effusion. Each centimeter, for example, in this space would correspond to roughly 200 mils. But again, to highlight, this is best done in a patient who is either like partially recumbent or mostly upright, because of course the fluid shifts in the thorax, and it's hard to assess, the true volume in the chest without a three-dimensional look. This is with the probe marker switched transverse now. The probe marker up. Okay, there's the aorta. This is very much like you'd see on a CT cut in half. Okay, there's the lung itself. There's the chest wall on the outside. And this image, this transverse plane is much, much better in a patient who's supine. So in ICU, this is one of the views that I think most people should become familiar with. It gives you a much, much better sense of pure volume. And then you can take this probe and sweep all the way up the chest and see how far that effusion goes. And supine, it's the same measurement. 1 centimeter equals 200 mils. So just measure from the lung to the chest wall. Okay, and I wouldn't take the largest, I'd take somewhere in between. But from here, you can measure from there to there, for example. And so this is quite large, probably correspond to around 1.5 liters. Obviously, is a huge fudge factor, and frankly, I'm not sure it really matters. What you want to know is this, small, medium, or large, and whether or not the patient will benefit from, diagnostic sampling or therapeutic drainage. So now, when we look at effusions, it's kind of hard to truly characterize them based off their appearance. So transitive effusions are mostly anechoic. Okay, so I think that's important. It's not that the appearance of being being anechoic would mean transitive or exudative. Think of it this way: if the pleural effusion is transitive by Light's criteria, it's most likely going to be anechoic, okay, and simple appearing. However, as we saw in case 1, okay, that's not always true. Okay, an exudative effusion can be anechoic. It can be complex non-septated, which means that there's actual echogenic material within the effusion. It can be complex septated. It can be very echogenic. And so, even like in case 1, if the appearance would seem simple, okay, it's still really important to realize that pretest probability, that clinical suspicion, is obviously critically important. And obviously that's like one of the cardinal things in clinical medicine, is that pretest probability and history are 99% of what you're going to be doing. So be very cautious. I would say that if you find a complex septated effusion, it bears in mind thinking about why that's there. For example, if they've had a previous chest surgery, maybe that's chronic, but if their chest has never been instrumented before, and they're coming in with a fever and a white count, that would be much more impressive. So in this case, in case 2, that was where I was coming from, was, this patient has not had a previous thoracic surgery, and comes in with this elevated white count, very pale, diaphoretic, and frankly, very ill appearing, that I felt this was more likely to be exudative and empyema versus anything. So any pattern other than anechoic has a higher likelihood of being non-transitive and usually warrants investigation, especially if it's unilateral. When you see bilateral oculated effusions, just less likely to be empyema, not zero, of course, but just less likely, because again, it's just like unlikely for a bilateral infectious process. And an anechoic pattern itself may be exudative, but in the right context, in bilateral, it's probably transitive. Like typically heart failure, we see bilateral anechoic effusions that are very simple. Again, the right patient population, the 70-year-old with known diastolic dysfunction and bilateral anechoic effusions, that's less likely to be an empyema or exudative effusion, obviously. But ultimately, if you need a diagnosis, then you need a TAP. So fibrous strands, unnecessarily acute or chronic. Okay, again, it's really important to consider the patient context. So case 3, this is a 56-year-old male who's day 6 post-transplant, post-liver transplant. He experiences severe shortness of breath. A med activation is called. Met team arrives. Patient sitting up. It has sat of 90% on 100% on a breather. Patient is tachycardic. Blood pressure is frankly normal. The general surgery resident's keen to place the new chest tube for right-sided effusion because the X-ray suggests that there is a new effusion. Here's the chest X-ray. Okay, I must admit, I heard about this case, and so obviously involved from that standpoint, and I thought, let's just wait. This guy's post-transplant. In this patient population, you have to be super careful that you obviously aren't poking the side with this new transplanted organ, and also just a number of reasons to be super cautious, which I'll get to. So this is the radiology report, okay, that there's decreased lung volumes, increasing right layering pleural effusion, and airspace initial change. Okay, so this is what the surgical team, which I think, to be honest, was rightly acting on. But again, I'm always very cautious with these because I think everybody needs to maintain a healthy degree of skepticism. So in examining this patient, it's quite high, like around the fourth interspace, anterior axillary line, and I came across this. Can anybody describe to me what you think you're seeing here?
Looks like diaphragm with subdiaphragmatic fluid fairly high up.
That's right. And then there's the liver, subdiaphragmatic fluid. We see the spine here. So obviously we must have, fluid above the diaphragm. So that's maybe lung there. Okay. So it looks like it's probably mixed here, like pleural and also subdiaphragmatic. Okay. So it's probably both. But as you pointed out, Charles, it's pretty high in the chest. Like this is actually where the chest tube would be inserted. The chest tube would be inserted squarely into the diaphragm. So looking up a little more, we can see this was around like third intercostal space, but quite lateral. So the diaphragm is still visible. And yes, there is a pleural effusion here and some consolidation, but this is actually like increasingly a very small space. And so the question becomes like you could drain this, but will this fix the problem? Like if this is the issue. Okay, so moving on the left side here, a little more normal appearing. It's a little bit lower, still somewhat high. There's the diaphragm, the spleen, and there's a pleural effusion, but it's not as impressive as the right side. Now, anything unusual about this diaphragm on the right? Maybe I'll ask, is it moving normally?
Doesn't seem to move at all, Brian.
Yeah. Yeah, so this diaphragm's not really moving at all. In fact, if you look at it closely, what you'll notice is that, it's actually moving upwards. Okay, in fact, it's moving upwards during inspiration. It's being pulled because the actual intrathoracic pressure upon inspiration will drop, of course. And so it actually pulls the diaphragm upwards, creating what we call a paradoxical movement in the diaphragm. Okay, so if you're doing fluoroscopy, this is what you would see is the diaphragm moves upwards upon inspiration instead of excursion, which is downwards. So this, in fact, is a paralyzed hemidiaphragm, and it's been displaced very apically. Okay, and it's left a very, very small intrathoracic space. Like there's probably, yes, there is pleural fluid here, but it's very, very small. So eventually, a comprehensive ultrasound was done, showing diaphragmatic paralysis, paradoxical movement, and a small right-sided pleural effusion. But again, a very small intrathoracic volume. So that's why I thought I'm not touching this guy with a 10-foot pole with a chest tube or thora. So we ended up putting this guy in BiPAP overnight because of the concern about just recruitment. And he improved steadily, and he did fine on BiPAP. Didn't progress intubation, and obviously, this complication can happen in the post-liver transplant setting, and I've probably seen about 5 of these cases before where it happens, either in the week following or in the month following transplant. Here's just an example. So the diaphragm should fall considerably. If you were to take an M mode and measure the excursion, usually about 1.2 centimeters is kind of the average. They're different left and right for measurements, but typically 1.2 should be the amount of excursion measured on M mode. But of course, this diaphragm is paralyzed. So if you were to measure the diaphragm for excursion, there's 2 ways you can do it. Either you can measure from the lateral approach or the anterior approach. You can see there's liver, diaphragm, place M mode through there, and you watch for that descent, and you measure it on a time motion display, and this should be about 1.2 centimeters. So basically, paralyzed hemidiaphragm, minimal small bilateral effusions, these B lines. We basically just put this guy in BiPAP and then gave him diuresis. Of course, Lasix diuresis, not Lassie diuresis, whatever that would mean. I swear I corrected that. I don't know what happened. So the summary of this is I would, never assume findings based on a radiographic report unless it's a CT, because it's just the degree of clarity and kind of geospatial resolution, and caution with landmarking for the diaphragm, especially with risk factors for diaphragm paralysis. And I think, I would argue you should never have to worry about the safety of inserting a chest tube for any reason, even in trauma. Like I think this should be used routinely because it's very easy to displace a diaphragm in really any setting, post-surgical or post-trauma. And, you know, as long as you can recognize what a diaphragm looks like and what a spleen or liver look like in ultrasound, it can just go above there. So again, a really key case where I think ultrasound helped to sort out what the true problem was. And this is actually a similar case we've recently had in our ICU, where another guy post-liver transplant had a pre-existing hepatic hydrothorax. He's been to ICU a couple times now. And this guy has unfortunately been back and forth with issues with de-recruitment on the right side. And, you know, here's the X-ray. This is from early October. You can see here again, a large amount of fairly dense consolidation infiltrate, which looks probably like a pleural effusion and some loss of aeration superiorly. And basically the report is large right pleural effusion persists and is unchanged, underlying extensive consolidation. You know, fair enough. And so the thought is, you know, we want, you know, I was asked to take a chest tube in, and I thought, well, let me take a look first. And so this is placed. This is placed exactly where I imaged him. Okay, just above the nipple. This is about the fourth interspace, kind of in the mid-clavicular line. We can see here that there's you know, this looks like liver. There's some fibrin stranding here. The diaphragm's not clearly seen, but I expect it's somewhere around there. Okay, so here's with the curvilinear probe, anterior chest wall, right fourth intercostal space. We can see this now. As we saw before, diaphragm, subdiaphragmatic space, some loculations, post-surgical, the liver, okay, and there's some lung sliding there with rib shadow. So this, in fact, is a very, very, very high diaphragm, okay? And, you know, any attempt to stick a chest tube in this gentleman would certainly result in untoward complications. And, you know, that's one thing that I obviously want to prevent, and I think we should all try to prevent that. But, you know, this can happen when we use X-rays and then point and shoot once the X-ray is interpreted. So I do think it behooves most of us to use ultrasound to clarify what these problems truly are to prevent these kinds of harms. So I hope today I've impressed you that there's fairly strong intuitive reliability. Before I just remember, Dr. Milovanovic has a case too, so I'll get to him in just a minute here. But I think ultrasound can help reduce the time to delay of a correct diagnosis, whether it's pneumothorax or pleural effusion. Pretty solid accuracy for, as we've seen, for things like, you know, complex or simple pleural effusions. And really it's simple to do. Like, it's the time requirement is like a couple of minutes and you get a pretty solid answer. And there's multiple studies showing that the sensitivity specificity of ultrasound for, you know, pneumothorax or consolidation or effusions or interstitial syndromes. So, you know, I think it is an important adjunct to caring for critically ill patients, and will give you a much better sense of what the true diagnosis, or at least ruling out what the active alternatives are. So in summary, thoracic ultrasound is a necessary adjunct to clinical imaging, and, you know, pretest probability and clinical phenotypes carry much weight in predicting disease types. So, you know, ultrasound is not some kind of miracle technology, but obviously it's an adjunct to what we do in our daily care for critically ill patients. And I suppose one big thing I would emphasize is that really have a lot of skepticism when looking at chest X-rays. It's not that the radiologists aren't good at reading them. In fact, they're very good, but they are chest X-rays, and, you know, unfortunately, they're just not CTs. So I'm gonna get last. Yeah, go ahead.
Ryan, is it okay if I just make a couple comments? So that's really important. I know you showed the sensitivity and specificities for the lung ultrasound, and that's in comparison to CT, guys, as the gold standard. Chest X-ray has sensitivities and specificities in the 50s and 70s. That's a really important point to make, that lung ultrasound even performs as well or just as good as CTs, and sometimes even better. Second comment I'll make is that for that case with the complex effusion, Brian's absolutely right. The sensitivity of finding a complex effusion is down. So it's not in the 90% range all the time. Sometimes if the effusion's very new, but it is an empyema, the complexity hasn't come yet. It might be just a little early. Same thing with like the FAST exam. The echogenicity and the complexity from a clot might not be there if it's a fresh bleed, right? So remember, the specificity of a complex effusion or fibrin stranding and things, that helps rule in. It doesn't necessarily rule out if it's still anechoic. And the last thing I'll say, and I'll impress this primarily on our trainees, if you ever work with me or Brian and you don't do a lung ultrasound before you reach for a bronch or you reach for a chest tube, you have not done the patient any favors. Left lateral decubitus chest X-rays are useless now. in the setting of having lung ultrasound. And the reason why I say this is because there's a lot of our colleagues in the States and in Canada who have become expert witnesses for patients who've had iatrogenic complications, or misadventures, or they grabbed the bronch when in fact it was a pleural effusion, or they grabbed a chest tube when in fact they needed a bronch. The lung ultrasound, again, is your friend. You see these sensitivities and specificities. You will figure that out, and you won't waste time, and you also won't waste equipment, and you'll get the patient, like, you'll be 100% correct. I know there's lots of times when I was in training where we'd reach for the bronch and we were wrong, and we'd reach for a chest tube and we were wrong. Now with lung ultrasound, you're almost never wrong. So yeah, that's the only things I'll say.
And if you like, honestly, once you've done a ultrasound, it's, if there's uncertainty after that, that makes for a very complex case, and that argues, especially for CT, like quite urgently, frankly. Okay, Laz, are you there?
Yep.
Can you give your case?
Yep.
Awesome.
All right. Thanks, Brian. We'll do this quickly, guys. So this is meant to be interactive. This is meant to be essentially an assessment of how we can acutely use point of care ultrasound in the lung to help diagnose what is a medical emergency. So the case is as follows. You have a 54-year-old lady. She's been in the ICU 15 days now. She's here with COVID pneumonia and a prolonged ventilation. She's morbidly obese with a BMI 55, hypertension, dyslipidemia. She has failed proning, and she's not an ECMO candidate. She's been on APRV for the past 8 days, 30 on 0. Over the past 5 days, her FiO2 has gone from 100% down to 60%, respirator 10, P high of 5.2, T low of 0.8, slowly improving vent settings. PF ratio is 95. She's critically ill. There's not much more to add. She's really kind of quite severe, but has been slowly making gains. So, seen that morning, vitally stable, on a little bit of NRP for sedation. Sats are okay. We do an upright chest X-ray, which is just seen on the right side there. At the time of the X-ray, the Sats are 92. As she gets laid back supine and the actual board is removed from the chest X-ray, she desats. And I'm called to the bedside 6 minutes later because Sats are now 80% on 100% APRV, same settings. And the nurse says, well, I can't hear much on the right side. Otherwise, the vent pressures and settings are unchanged. I took one look at the trachea and one feel of the trachea, and I could not feel anything because her neck was one big mass, so I could not determine what was going on. So, and I went to find the X-ray. At the nuns, we don't have digital X-rays, so you have to wait for it to load up. So I went, took a look, saw this, and I said, oh, it's just COVID. I wonder what's going on. So, bring out our trusty ultrasound. So, does anyone want to comment on what you see here? This is L1 and R1 on either side. I'll play them again for you here. Any comments on what you see here?
Laz,
So,
is
yeah.
there a lack of lung sliding on the right side?
Yeah, I don't see any lung slide and I don't see any B lines.
Yeah.
So, and I want to compare it across the two, but right now I see pleural line. I don't see really any A lines, and you can tell her body habitus is affecting a good image here. These are not particularly good images, but I am concerned there is a difference in the way in which the pleura is moving on the right side. So what we'll do is we'll then go to point L2 and R2. So that was L2, here's R2. And so what do you see here?
No lung sliding, no B lines.
Exactly, but you see a really nice A-line pattern. So you know you're visualizing, you're in the thorax, you're seeing into the space, but you see no B lines and no slide. What does a lack of B lines mean in this case? So usually when I think of B lines, I think of pleural apposition. In order for you to have B lines radiating through the lung, you need to have the parietal and visceral pleura touching. So I'm worried about there being some of that. Brian, were you going to say something? I think you were muted for a sec there.
Yeah, sorry. There's a message from Nicholas Quigley that no lung sliding, belly movement because of pneumothorax.
Yeah, so that is the primary concern. Now we'll talk about it's important not to jump to our diagnosis, but that is what we're thinking about here. And you can see as we go down the lung, all the way to here we're in points L3, L4. Sorry, here's L3, L4. And you can see again, no slide on the right, no B lines on the right, lots of lung slide on the left. So what's the differential for this? So remember that there's a broad differential for a lack of lung slide on a lung ultrasound, including patient being apneic, pneumothorax, massive atelectasis, mucus plugging, pleurodesis, pleural disease, pleural effusion, mason intubation. The part of this that obviously stands out is that you also have no B lines, so you're worried about no pleural apposition. So this patient's stats are 85, and I had time to call them back and get a repeat chest X-ray as I was setting up for the chest tube. So my primary differential in this case is pneumothorax versus a left main stem intubation because of the positioning of the patient or a big mucus plug. So as I was opening the kit for a chest tube, the X-ray was completed, and you can see here, there is a massive right-sided pneumothorax with some signs of tension on the X-ray and then in keeping with our clinical syndrome. I didn't need the X-ray to make this diagnosis, but as I was getting set up, they asked me if I wanted a repeat X-ray, and I said, sure, bring them in, because I was just setting up the kit. And so a chest tube went in, the patient's hypoxemia immediately resolved. This is the X-ray post-chest tube insertion with rapid re-expansion of the lung. Now, this patient actually didn't have any change in their event settings that led to a pneumothorax. They just had progressive fibrosis of their lung, which led to this in the setting of APRV, which we know is a risk factor for pneumothorax.
Hey, Laz, you put in a real chest tube.
Oh yeah. So I'm a big fan of pigtails, but I also believe that in the ICU, when you're doing emergency things, finger to pleura is where I go. So yeah, no, I'm a big fan of surgical chest tubes. Don't tell Brian.
I like to put in multiple pigtails, like almost like a pincushion type approach. Just I'm just kidding.
Yeah, add all the
totally
Frenches
agree.
together, they'll add up to eventually a surgical.
Yeah. So to discuss this case a little bit, this gave us a rapid bedside diagnosis for a broad differential. In this case, I don't even have a digital X-ray, so I can't get these images immediately. We can answer multiple questions at once, and it can certainly be used in both an acute setting as well as Brian pointed out, in a diagnostic process. Now, it needs to be used in the context of a clinical question. So as you saw in that first set of images for the ultrasound, the point L1 and R1, when someone is ventilated on high PEEP or high APRV, you don't see a lot of lung slide on the left side either. And in the inappropriate clinical context, you may say there's a pneumothorax on the left side as well. There is not. This patient is hyperinflated and not ventilating their upper lobe at all because of the APRV. So it's important to recognize the right clinical context for the images you're taking and to use that to make your decisions. So with that, I'll wrap up this case. Does anyone have any questions about this or the diagnostic process?
So Laz, I'm just gonna... Oh, sorry, go ahead, Mike.
Yeah, it's just fabulous case, Laz. I think it really illustrates it very, very well. So thanks for presenting it.
Yeah, that's great.
Yeah, great job, Laz. I'll just say a couple of comments. A lot of our trainees sometimes know from the ultrasound course that, lung sliding, B lines, as well as lung pulse can help you rule out a pneumothorax at the point of insonation, 100%. If you have any one of those three things, it rules it out. A lot of the trainees also try to look for lung points because that rules in a pneumothorax. But one caveat I'll say to them is that the larger the pneumothorax is, the more likely you're not going to find a lung point, right? Because it's so massive, all you're going to see is an A-line pattern with no lung sliding, because there's no apposition, because the air is just basically pushed the lung down. There's no, so if you don't find a lung point, does not mean it's not a pneumothorax. In fact, if you slide all the way from top to bottom and you don't find any lung sliding at any point, just imagine that is a massive pneumothorax, and your chest X-ray can confirm it, but you could probably just go ahead. I think you guys ended up needle decompressing and then putting the chest tube in. Was this the case that you did with Leon? Yeah. Okay.
No, this
Really good point. So remember back to that other case with the guy with the elbow and things like that. I think Brian and the rest of the ultrasound crew here ended up doing his echo too, and they ruled out endocarditis. Like, so the thing is, when you're already in there, gowned up PPE for, you're gathering all this information, and you're basically doing what I love to do, which is whole body ultrasound, and you're getting it all in one go. You're not wasting PPE. You're already in there anyways, doing lines and tubes and other stuff. So yeah, it's a one-stop shop. Like, that machine is just, it's so powerful, and basically your radiology and cardiology put together. So it's awesome.
Yeah, thanks, Vince.
Excellent. Well, that concludes our first rounds of the year. Next rounds will be in